Hi, everyone. So today's office hours is about something called shy bowel. The technical medical term is parcopresis, and it's also known as psychogenic fecal retention. And in order to understand what shy bowel is, let's take a little walk back through history, and then I want to tell you about a patient of mine. I'm going to change a few of the identifying features because obviously nobody wants to be discussed on my office hours in a recognizable way. And let me just remind you again that what I'm telling you here is for educational purposes. So I'm not diagnosing you, I'm not treating you, I'm not giving you medical advice. Okay. All right. So in, sort of turn of the century, theaters and train stations and hotels had lounges where when you literally had to urinate or defecate, you went to lounge. And they literally had couches in there, sometimes velvet covered couches and, ottomans, and it was a lounge. And so we still think of that, people will still say, men's lounge, women's lounge, or all gender lounge, which is preferable, of course. So we still think of these places, or think of the terms that we use to describe the places where we go to urinate and defecate. We call it a restroom, a powder room, a lounge, a bathroom. I don't know about you, but when I'm at the movies and I have to go take a poo, I'm not bathing. I am simply defecating, right? But we still call it the bathroom. Occasionally, I think in Europe more, people will say the toilet, and it will say toilet. And, people say, well, le toilette, and without the same embarrassment, but I rarely hear it referred to as a toilet here. I think that would raise some eyebrows if you're like, where's a toilet? People want to know, where's a restroom? Where's a bathroom? And again, we're not going to rest, although back at the turn of the century, the early 1900s, people were resting. At intermission, the ladies would go and they would lie back. And I don't know, the men would like go and smoke or something, but the ladies would lie back on these chaise lounges and rest. It's not what's happening anymore. But I think the terms that we use still speak to the discomfort, quite frankly, that we have about what is going on in there. Not so much urination, but defecation, having bowel movements. We still feel a lot of discomfort with that. And if you look at animals typically will go off and find kind of a quiet, private spot, animals in the wild. Dogs and cats are a little different because they're domesticated. And I have to tell you, I always feel bad for these dogs. So they're kind of looking around like, really? I've got to drop it here in front of all you all? Can a dog get any privacy? But that privacy issue was more about safety, right? Because when animals in the wild are moving their bowels, they are really vulnerable to, being eaten, etc. And so the issue of privacy was more about safety and making sure that they're not going to be attacked and eaten while they are moving their bowels. And I assume that genealogically that it was about safety for us too, but it's morphed into something else. And to kind of understand what that something else is, let me tell you about a patient of mine, Sherry. Again, not her real name, but this is a real story. Sherry was in her late 50s when she first came to see me, and she had severe constipation. She basically said, look, I've seen 5 or 6 gastroenterologists. My constipation is off the charts. Nobody can get my bowels to move. Show me what you got. And we went through what she was doing. Diet was pretty good. I added a fiber supplement in the morning. I start with the gentle stuff. So I added a magnesium cathartic at night, which is just a nice way of saying, catharsis, as in moving your bowels. Added some magnesium. One of the really important things when you're dealing with constipation is making sure people are well hydrated. So I generally recommend at a baseline, like the minimum, half your body weight in ounces. So Sherry was about 160 pounds. That was about 80 ounces of water. So I said 80 ounces has to be, this is where I always like to take a little hydration pause. My flask is 40 ounces. So my minimum, I try to do a few of these, but I actually aim for 3 of these, 120, which is not my half my body weight in ounces. It's more than that, but I try and do that. So I said, Sherry, you've got to make sure you're drinking at least 80 ounces of water, just plain water. I don't want you counting anything else in that 80 ounces. And let's have that as a minimum and go from there. She was really good with the hydration. And the other thing is you want to make sure people are moving, right? Because as I'm fond of saying, if you're not moving, neither are your bowels. So peristalsis requires movement generally to get it going, which is why people in nursing homes, for example, tend to have serious problems with bowel obstructions and slow transit because they're just lying there, sitting there. So Sherry, was pretty active. I had her doing some more stuff. And she had a colonoscopy and some other tests that really just didn't shed any light on things. She'd had a CAT scan of the abdomen to make sure that she didn't have a tumor or something that was pressing on her bowel. As I said, the colonoscopy was pretty unremarkable. And so, we tried increasing the doses. I like to take a synergistic approach with things where I'll use, more fiber in the morning, sometimes a mix of psyllium husk and acacia fiber. If they don't tolerate the psyllium, for some people it bloats them. So we're doing a mixture of psyllium and acacia in the morning. We're doing the magnesium at night. I even added in some Miralax, which, as many of you know, is an osmotic cathartic. I don't like to use it long-term because it's a first cousin of polyethylene glycol and antifreeze and so on, but it's fine in the short term. So we were blasting her with a lot of stuff. And one of the tests I did was a very simple test called a Sitzmark study, which is a test we do with the radiologist where the patient is given a little mouthful. It's really a little capsule of markers of radio opaque, meaning they turn up, they will show up on an x-ray, markers to swallow. So they swallow the markers at day one, and then we bring them back in for an x-ray every day over a series of days. And what we're looking for is the pattern of markers in the colon. So we want to see all the markers make it down to the colon. Yes, we want to make sure there's not something obstructing things higher up. And then if the markers are typically spread out throughout the colon, think of the colon as this reverse horseshoe, we know that it's slow transit through the colon. In Sherry's case, all the markers were clustered right at the bottom, at the back door, as I like to call it, right? So everything was, her colonic motility was pretty normal. Things were getting to the end, but they were all clustered right there at the end of the colon in the rectosigmoid area. So what that tells me as a gastroenterologist is that there is likely a sphincter mechanism problem. And that is exactly what was going on with Sherry. But this is what she disclosed to me after about 1.5 years of taking care of her, which really explained everything. When she was, I think around in middle school, I think she was around 12 or 13 when this happened. She was going to a camp in the Catskills that everybody in her family had attended. And she was really excited that she was finally old enough to go. And one of the things they did that first week of camp was they did like a get to know you hike with her dorm, which was a girls' dorm, and the boys' dorm next door. So it was, think about, 40, 50 kids, half boys, half girls. And they set off on this all-day hike. Now, Sherry had this urge to go in the morning, but she was really worried that the hike would leave without her. And, she wanted to be with the group. So she thought to herself, okay, I'll just go later. And she set out on the hike. But about 2 or 3 hours into this excursion, she really had the urge to go. So when they stopped to have lunch, she decided to head off into the woods, look for privacy, safety, right? Like animals that we are. And so she found this spot, pretty far away from the group, a little grassy knoll. There was a tree. It was very private. And she had actually brought some tissue paper with her because she knew when she set out that she had this urge to have a bowel movement. So she had her tissue paper. She squatted down, and you guys know what's coming, right? She was literally, the stool was literally exiting her bottom when a group of boy campers came across her. They had seen her leave and they decided, oh, we're going to follow her. And literally mid-defecation, mid-stool exit, she's squatting down. She has her pants down, her underwear down. And this group of boys happens upon her. And of course, squeals of laughter and pointing and so on. So can you imagine, you're a 12 or 13-year-old girl. You are having a bowel movement in the middle of the woods and a group of boys discovers you. I just cannot even imagine. Well, she got back to camp. She told her counselors that she was sick. She had them call her parents, pick her up. She never went back to camp. And she never had normal bowel movements after that. The feelings of shame that were so ingrained in her that day as a young girl from being discovered in this most sort of compromising of positions fundamentally affected her bowel movements and her ability to have a bowel movement in the future. So Sherry had a really extreme case of shy bowel because what she confided to me was that she could not have a bowel movement at home if her family members were present, her husband or any of her 3 fairly adult children, late teens. None of them. They literally had to leave the house for her to have a bowel movement. She had a house with lots of bowel movement. Oh, she had a house with lots of bowel movement. She had a house with lots of bathrooms. She had bathrooms all over. She had a bathroom in the basement. She had a private master bathroom. She tried sending everybody downstairs, but she just couldn't. So literally, she had to time her bowel movements at these really awkward times, like after the kids were all gone to school, her husband was gone to work. And it just, really her whole life revolved around this issue. So Sherry's case was pretty extreme. When I was a GI fellow in New York, I had a friend who lived in the same apartment building who had a case of this. She was a model and she was pretty fancy. She had a fancy boyfriend, some actor, musician, or somebody who had a fancy apartment. There was a lot of fanciness going on with lots of bathrooms, but she would take a cab home. This was pre-Uber. She would take a cab back to her apartment to have a bowel movement. And they went on vacation to, I think they went to the Bahamas, somewhere in the Caribbean for 3 or 4 days. And she literally did not have a bowel movement the whole time. She was so concerned that he would see it, he would hear it, he would smell it. She held it. And I'll tell you, this is a true story. She came back and I was on call. I was doing my GI fellowship at Mount Sinai. And I got called to the emergency room for fecal impaction. And I had to manually disimpact the patient who was my friend from the apartment building. She had come in and I was on call. I was like, listen, I'm so sorry, you're out of luck because I'm the one on call today. And I'll tell you, manual disimpaction is as terrible as it sounds, both for the disimpactor and for my friend, the disimpactee. So you do not want to get to that position. And, again, these were sort of extreme cases. And look, right, nobody wants to have a bowel movement in public. It's not in our DNA. Again, that issue of safety also involves privacy, right? We don't want to be devoured by the predator. But taking it to an extreme where, you can't have a bowel movement on vacation with your boyfriend or girlfriend, or you can't have a bowel movement in the house with your family around. So think about where this develops for so many people. And for those of you who have kids, I really want you to think about it. Like, kids spend a lot of their time at school, just like we spend a lot of our time at work. Now we spend a lot of our time at home, post-COVID or intra-COVID. I'm not sure we're really post-COVID, but you know what I mean? So things have changed and a lot of us are working more from home. And I dare say, if you suffer from shy bowel, that has probably been a really good thing. I mean, I know a lot of my patients with inflammatory bowel disease, with Crohn's and ulcerative colitis, who have bowel urgency, are delighted to be at home because access to the bathroom is a big issue for them. It's a different issue of urgency. But getting back to kids, this often develops in childhood, and it's more common in girls because girls in general, and I realize it's a generalization, but girls tend to be more fastidious about where they use the bathroom and is it clean and can people see? And I've been in some of these school bathrooms. There's like a 6-inch gap between the door and, the end of the stall. So people can see through, they can see exactly what you're doing under. I mean, I was in the airport the other day. Where was I? I was in the Charleston airport a couple of weeks ago, using the bathroom, defecating. And I am a, I can go anywhere kind of gal, but I was surprised. There was a lot of space in that stall with I didn't quite make eye contact with somebody outside, but close. And it's uncomfortable, even for me, who's a champion pooper, and I can literally go anywhere. I don't want to look through the door as I am trying to release my bowel movement and make eye contact with the person who's waiting. So Charleston Airport, get it together. Okay. So again, kids at school, they don't want to be sitting there while it's making noise. It's smelly. There's, the dropping, the splash sound in the toilet, or straining sounds, or there's gas coming out. So they're farting at the same time that they're having a bowel movement. All of these things, right, that we all experience. Also, in some schools, you still have to put your hand up and ask, can you go to the bathroom? So there's that too, right? I mean, it's embarrassing for a lot of people to have to acknowledge that they have to urinate or defecate. So this often gets set up in kids. And I will have patients who tell me, oh, yeah, I never, ever, ever had a bowel movement at school. And this confuses everything because our bodies are designed to work with the circadian rhythm. When the sun rises in the morning, things are supposed to happen. And one of the things that's supposed to happen is we are supposed to have a bowel movement. Once we break fast, whether it is coffee or tea or, an omelet or an English muffin or whatever it is you're having for breakfast, once your stomach senses that food, there's a reflex called the gastrocolic reflex. And your stomach sends a hormonal signal to your colon saying, okay, food is coming in, clear things out, make way. It's also tied to other hormonal secretion that's based on the light dark cycle. So it's not just a gastrocolic reflex. So even if you tend to not have much in the morning, like I do, tend to not have much, even if I've had a sip of water, I often have that urge to go. And again, that's the circadian rhythm and the hormonal secretion in our body that's tied to that light dark cycle. If you are ignoring that and you're having bowel movements later in the day, that can really confuse things. So let's chat about what happens with that confusion. And then I want to take questions. So I'm going to chat for about another 5 or 6 minutes about what happens with the process of defecation, because this is the heart of psychogenic fecal retention, parcopresis, shy bowel, talking about the same thing, is this sphincter mechanism, right? So I have to do something challenging now, is I have to make the process of having a bowel movement very, very interesting. Let me just take this quick question from Naomi. Our high school would rotate locking bathrooms to keep kids from smoking in them. Yes, I've heard that too, to keep kids from smoking and vaping. So can you imagine, like, you have to have a bowel movement and you have nowhere to go? That's crazy. That's crazy. Should lock the teachers out of their bathrooms and see how they like it. Okay. So bowel movement 101. And this stuff, I mean, I know I'm biased, but I think it's fascinating because when you understand how it works, then you can understand what you need to do to get stool nirvana and to have everything working smoothly, right? And obviously hydration and diet and movement are really important, right? Eating enough fiber, drinking enough water, moving around enough. These are all really important, but the actual mechanism and position, we'll talk about squatting on another one. We'll go over squatty potty and all of this stuff on another office hours, but let me explain to you how it all works. So the rectum is a reservoir. It's a storage organ. It's like a closet, literally, right? And the rectum is about 6 inches long by 1 to 2 inches wide. And so that's not that big, but here's the thing, it can expand. So the threshold volume at which most people will feel like they have a little something in the rectum is about 20 milliliters. Well, what does that mean? It's a couple tablespoons, right? Between 1.5 and 2 tablespoons of stool. And it depends on the consistency, of course, is the threshold volume at which, if you are kind of like a sensitive pooper, you might feel like maybe there's something. So that's the minimum volume. But the threshold volume of what the rectum can hold is about 400 milliliters, right? So your rectum can expand from 20 milliliters to 400 milliliters. That is a tremendous amount of stool. It can expand like a balloon. Now, people who have ulcerative colitis, where the rectum is uniformly involved, their rectum undergoes fibrosis. It becomes stiff, and it goes from being a distensible balloon to being like a lead pipe. And that's why people with colitis have so much frequency. Like, they often have the same amount of stool, but that lead pipe can only hold like a tablespoon or two. So every time a tablespoon or two comes down, they've got to go, and they've got to go again and again and again. And so again, think lead pipe, colitis, fibrosis, balloon, normal. So most people, in the absence of colitis or some other inflammatory condition of the rectum, have this very distensible rectum. So that sounds great, right? Perfect. You just told me my rectum can go from 20 milliliters to 400 milliliters. So I've got all day. I can go shopping. I can take my kid to school. I can watch the news, right? No problem. Big problem. Big problem. The problem has to do with the sphincters. So we talk about the rectum, but the rectum is just a storage organ. What's actually holding the stool in and pushing it out? 2 sphincters. You have an internal sphincter. And the thing I want you to remember about the internal sphincter, besides it being internal, the innermost one, is that it is involuntary. It's like heart rate. You can't, or blood pressure. I won't say you can't control it. It's difficult to control. People who meditate, people who, are very in tune with their body can do things to increase or decrease their heart rate. But for most of us, our heart rate is fairly involuntary. And of course, our stress level and our level of anxiety, and we're going to circle back to that, influences our heart rate. So if we're very stressed, often our heart rate can go up, or our heart rate variability can change versus if we're in a more relaxed state. So stick a pin in that. I'm coming back to that. So internal sphincter, involuntary. And the internal sphincter in a normal resting state is clenched tight. It's clenched tight to prevent stool from leaking out of your rectum. Remember, stool is being laid down all the time, right? As you eat and the food gets churned up into particles in the stomach and transported through the small intestine, and things are absorbed. And then, bile salts are added, et cetera, dead bacteria, and you end up with this more liquid stool. And then as it goes through the colon, water gets reabsorbed, you end up with a more firm stool at the end. Well, that process is happening, throughout the day and night. And so less at night though. And so if your internal sphincter wasn't clenched tight, as stool got laid down in your rectum, you might be leaking stool, right? That is not a good state of affairs. So the internal sphincter is in its steady state, clenched tight, and it has to relax in order to let the stool out. Now, how does it know when to relax, right? There are sensors in the wall of the rectum that detect, remember I talked about the minimum volume and that threshold volume, that detect when the rectum is full. So those stretch receptors get triggered as a rectum becomes fuller of stool, and expands. And then a message gets sent to the brain from those stretch receptors in the rectum. You all know about the gut-brain connection. It's real. And then the brain then tells your external sphincter, which is voluntary. That's like moving your head or hands, right? You can control that. So then you're like, oh, I have to go. You get that urge and you sit down and you then contract your external sphincter, and that pushes a stool out. But that doesn't happen really successfully unless your internal sphincter relaxes. So your internal sphincter, again, just go over it. Rectum fills up with stool, triggers stretch receptors on the inside of the rectum. The stretch receptors send a signal to the brain that, things are getting full, maybe a good time to let some stool go. Brain sends a signal back. External sphincter, you push down, bear down, stool comes out. Okay, so what happens when your rectum fills up? You have that urge, the receptors trigger all of that, but then you clench your external sphincter and you don't let it out. Confusion, right? That's not what's supposed to happen. The internal sphincter has relaxed. Now the external sphincter is supposed to push it out, but you have decided, I'm not going, because guess what? I'm in the Charleston airport and that crack between the stall door and the end of the stall is 6 inches wide. And this woman is looking at me like, hurry up, I need to go. And I'm just not comfortable. And so I'm not going to go. So you basically pack it all back up, right? You make sure your external sphincter, you are not pushing it out. And worse, now you get something called reverse peristalsis, which I like to call prairie dogging. I know it's very visual, right? But you see the prairie dogs. I've only ever seen them at the zoo, poor prairie dogs, but they have these little like caves and they poke their head out and then they poke their head back in and they poke their head out and they poke their head back in. So I have this term that I will use at home where I'll say it's prairie dogging, right? Like my stool was trying to come out, but it went back up. And so now as you have prairie dogged your stool back up the colon, the stretch receptors are not going to trigger because the stool is going in the wrong direction. And you are not going to have a bowel movement anytime soon, which is why I know many of you have experienced this when you felt that urge to go and you ignored it for, I'm sure, a very good reason. Guess what? You think, okay, I'm going to circle back to this, after I drop my kid off. Guess what? No circling back. Then you find you're constipated. And later in the evening, when you're ready and, time is right, guess what? It's prairie dogged. It's not coming back. It leads to sphincter confusion, bowel confusion, and paradoxical bowel movements, which is, you're trying to go and it's squeezing instead of relaxing, or it's relaxing instead of squeezing. And this can lead to the kind of constipation that is very difficult to treat, because no amount of fiber, magnesium, cathartics, etc., even laxatives, which I, don't recommend using stimulant laxatives in the long term because your colon can become dependent, but it's very difficult to overcome that, because this is happening at a central nervous system level where the sphincters, there's discoordination, if there's a word. There's a lack of coordination between the sphincters. And this is why on Sherry's SITS marker study, there's all the markers were just piled up at the back door, literally like the door wouldn't open. Okay. And so this is why it is so, so, so very important to heed that call when you have that urge to go. And look, I guarantee you, everybody poos, right? Some people poo into a bag if you have an ileostomy or a colostomy, but everybody, we ingest food, we absorb the nutrients, etc., and then the waste matter comes out, and there's no getting around it. Every single living human being has bowel movements. So what I try to counsel my patients is, of course, if you are in a work or school situation and you have that individual bathroom, go for it, right? And luxuriate in it and get off your phone, because your phone is just going to slow the process down. Do not do Wordle in the bathroom. I've been guilty of that a few times because I like to do Wordle first thing and then text all my friends like, I got it in 3. But Wordle tells your sphincter, like, you've got all day, right? You want to be efficient. So resist the urge to take your phone in, keep it out, get in, do your business, get out. And, I'll tell people, like, push if you feel like you're straining and it's not working, get up, drink some water, maybe walk around, try again later, but do not hold it. Holding it can lead to some serious problems. Again, reverse peristalsis, prairie dogging, all kinds of issues. All right, so we are almost at halfway. So let's take some questions. Okay. Oh, not the teachers. The administrators would rotate the locking, but well, we should lock the administrators out of the bathroom in that situation. Somebody had mentioned that the administrators at the school would lock the bathrooms to prevent kids from smoking. And I'm just saying that's a cruel and unusual thing to do. And we should lock those administrators out and see what that feels like. Okay. All right. So we have a question. Any suggestions to improve motility with colitis and IBS? Yes. So I'm assuming that your colitis does not involve diarrhea, because if it did, you would not be trying to improve motility. Depending again on what type of colitis, you have to be careful. If somebody has ulcerative colitis and has that sort of lead pipe colon, you want to be careful about increasing motility, because that can lead to bowel movements that are difficult to control. But you mentioned irritable bowel syndrome also. And remember, with irritable bowel syndrome, you can have diarrhea predominant, constipation predominant, or you can be what's called an alternator, where you're having both. So let's assume that you're talking about constipation predominant irritable bowel syndrome. And if I give you a list of things that cause motility disturbances, it would be very long. So medications are high on the list. So, pain medication, certain antidepressants, a lot of these medications can affect bowel motility. So that's one thing to think about. Food is another thing to think about if you're eating a lot of things that are very binding and constipating. So a lot of bananas, a lot of rice. These are some of the things that typically are a little more constipating. Things also if you are eating a ketogenic or a low carb diet, the sales in fiber supplements like skyrocketed as low carb diets sort of, became popular. So low carb diets are almost guaranteed to make you constipated. And particularly if you're eating really low carb, like less than 50 grams of carbohydrates, or like a ketogenic, less than 20 grams kind of thing. So diet is really key, right? You need enough fiber to bulk the stool to have a successful bowel movement. So that's part of motility. I mentioned hydration, minimum half your body weight in ounces of water as a bare minimum. I mentioned movement. Many of us are sitting more. We're more stationary at home. We don't have as many activities of daily living. That's helpful. So let me tell you about some other things too. Ginger can be really helpful for improving motility. So I like to put some ginger in my smoothie if things are feeling a little sluggish. I don't really love the taste of ginger that much in the smoothie, but I'll put it in for motility. or brewing a ginger tea, a really strong ginger tea. So you can cut up the ginger root, steep it in hot water, drink that. That's excellent for motility. Fennel seeds can also help motility and digestion. They tend to help more with gas than motility, but that's something else that can do it. I'm a big fan of magnesium because it's pretty gentle and it's not a stimulant laxative, so your colon doesn't become dependent on it. So I will use magnesium oxide anywhere in the range from 2 to 800 milligrams a day. Some of my patients like Calm magnesium, that powder stuff, and they feel like it helps relax them and it helps with bowel movements too. So Calm magnesium is another form. For people who are really struggling with constipation, there's something called oxy powder, and that is an oxidized magnesium product, and it is jet fuel. Be careful with it, and only use it as recommended for a certain period of time. It's not something I recommend long term, but 1 to 4 capsules at night. And with the oxy powder, you will feel it when it starts to work. A lot of people get painful cramping, like it will stimulate things. It's not a senna containing laxative where you develop long-term dependency, but it is pretty strong. So that's Calm would be the milder form, and the oxy powder would be the more aggressive form for improving motility. And then, fiber can help too, but you have to be careful with fiber, because if you're using like psyllium husk, which I recommend a lot and use a lot in my practice, the psyllium husk, if you're taking a large dose and there's not enough water and things are kind of dry in your digestive tract, it can glob up and end up sort of making you more full and bloated. Or if you have a very twisty, turny, voluptuous venous colon, the fiber can get stuck at some of those hairpin turns. So I will often start people on acacia fiber, which is a soluble fiber. So it's not as robust really for bulking the stool, but it is better tolerated in some people. And I'll start them with just a teaspoon of acacia fiber with each meal, and I'll gradually increase it to 2 or 3 teaspoons with each meal, and then I'll gradually have them do most of it earlier in the day. But the acacia is a more soluble fiber, and you have to do it with lots of water, right? Because it's like plumbing. If you have a clogged pipe, you've got to run thin liquids through it. You're not putting oatmeal through your clogged pipe to get things going. So lots and lots of water will help. And I'll tell you again, I consider myself a champion pooper, but the other day we were driving back on a long road trip, and we were driving back from Vermont, and I was trying not to drink a lot of water. And so the next day I was like, wow, I need to really make up for this. And the next day I literally drank 150 ounces of water, which is, a threshold I never get to. And I was amazed the following day, like things were flowing like you could not believe, right? So my kind of secret formula is, I like to get a sweat on. And if I'm really on my game, green smoothie, but at least like some lentils, brown rice, some greens, and then a lot of water. And it's, definitely good things are happening. All right, let's take some more questions. Okay. Sigmoiditis. Okay. Was the inflammation in the colon? Well, so again, you have to be careful here, because if you have sigmoiditis and you have an inflamed colon, that can lead to less water being reabsorbed from the stool into the bloodstream and a looser stool. And so if you increase transit time with a looser stool, you can end up with diarrhea. But I am assuming that is not the case with you. Otherwise, you wouldn't be asking that. So let's say you have a situation where you have inflammation in your sigmoiditis, but you tend to be more on the constipated side. I think something gentle like magnesium would be a good option for increasing the motility for you, and maybe adding some ginger in. I would be careful with doing a lot of fiber in the form of a fiber supplement if there's active inflammation in the sigmoid. If your sigmoid isn't actively inflamed and you can tolerate some acacia or some psyllium, that could be very helpful too. Okay. Is there a way to have a bowel movement alone in a car without woods to duck into on a long trip? Jean, you're just a person after my own heart. I am going to, on the next one, I'm going to show you my urinal. During pandemic, our daughter's a rower and she was rowing down on the Potomac, and all my usual bathroom spots, the Starbucks, blah, blah, blah. Nobody was letting anyone, they're barely letting you in, much less like, you're definitely not coming to use our bathroom. And one day I had my car on, and long story, the battery went dead and I was waiting. The windows were down. I couldn't leave the car because it was, the windows were down and the battery was dead. I couldn't turn the windows up. So my husband was coming down to help me. And it took a while for him to get down. And I had to pee like nobody's business. I mean, he came, I literally yanked him out of his car, jumped in his car, drove somewhere, peed. And I was like, okay, this is not happening again. So I got this thing that I called a furinal, a female urinal. I mean, if you look up female urinal on Amazon, there are all kinds of different ones. And I bought like 6 or 7 different ones and then kind of experimented to see what worked the best. So this one is like a funnel. And then, like a urinal bottle with a funnel thing. And you literally can just, put it down over your crotch and pee. I have demoed it. Like I've gone and used it. And I say to my husband, can you tell? And he's like, yes, I can tell. You're like raising up out of your seat and doing weird things. But I'll tell you, in a pinch, it just peace of mind having that. And I have patients who do have the like portable potties for kids, a larger version of those, also from Amazon, I believe, in the back of the car. And for some of for my patients who have bowel urgency, usually my colitis or Crohn's patients, I will write them a letter so they can get a handicap tag to put on. And I always say to them, look, don't abuse this, right? Like only use this if it's really a bowel emergency. Don't park in the handicap spot because there's no parking. And I will say they uniformly are very good about it. But I will write a letter saying, my patient has a chronic autoimmune disease, Crohn's or ulcerative colitis, that results in bowel frequency and urgency, and they sometimes need immediate access to a bathroom, so that if they're driving, they can whip out their handicap decal and hang it and quickly pull into the handicap spot and make it to the bathroom. So, if you have an actual medical condition that qualifies for that, which would be Crohn's and ulcerative colitis, they are protected under the Americans with Disabilities Act. And that is a very legitimate use of a parking hang tag for that. But let's say you don't have that, or you're driving and there is no place to pull it into, regardless of whether you could pull into the handicap spot. So getting some kind of, children's potty thing that you can have in the back of the car is just peace of mind. Like I've used my Furinal twice. One, actually, I needed it, and the other experimenting, much to my husband's dismay. And I'll tell you, it's in the back of my car, and I just feel good knowing that I am not going to have an accident in my car if, push comes to shove and I'm in traffic or something, and I'm, always hydrating in the car. So that's really good to know. So is there a way to have bum alone in a car without woods to duck into on a long trip? I would say that you could look at some of these, children's potties, depending on what size you are, portable potties, and see what you could create. I think that a brilliant thing for those of you who are engineers and inventive would be some kind of car seat where you can slide open something, have a bowel movement, close it, and then it gets turned into fuel. What do you think about that? You could somehow, because methane, right? Burn it and it could go for fuel efficiency. So instead of an electric car, like a stool powered car, I don't think that's happening anytime soon, but I've always thought like that could be a good thing. Okay. I am not constipated or have diarrhea with colitis, but I just cannot empty in one go and have urgency too. Okay. So you gave me such an important clue there where you said you cannot empty in one go and you have urgency, is you may need to bulk the stool a little bit. Now, again, be careful with the fiber if you have the colitis, but a lot of my colitis patients, I will put them on oatmeal in the morning, or I'll put them on a little psyllium husk in the morning. And what it does, it consolidates some of those smaller movements into one bigger movement. So instead of 4 or 5 stuttering bowel movements, they're having one nice big bowel movement. So now that you gave me that additional info, I would say try, start with half a tablespoon of psyllium husk, work your way up to a tablespoon, try doing some oatmeal in the morning, and then report back and let me know. But again, I'm not your doctor, educational. Okay. Mostly plant-based with occasional fish. Wonderful. Yeah. Magnesium citrate works too. Magnesium oxide or citrate. Slippery elm, we think of in the GI world as more for liver than a cathartic. So, I don't have a lot of, it's not something that I would use for constipation if it works for you, but we do use that in the liver world for liver disease. Okay. Constipated daily, 4 years. Oh no. Bowels changed overnight. Even then, stools look thin like pencils. Colonoscopy equal no obstruction. Anal manometry normal. I'm glad you mentioned the manometry. I want to ask you, colonoscopy, no obstruction, but did you have diverticulosis? If you did, that is coming up in an office hours this week in June. I don't remember if it's next week or the week after, but if you had diverticulosis, and often the gastroenterologists don't tell you, right? Because they're looking for sexy things like polyps or a tumor. And because more than 50% of the population over 50 has diverticulosis, often it's something they just don't mention. But I want you, Lynn, to go back to that colonoscopy report and see if you had diverticulosis. Okay. Manometry normal. And what that is, anorectal manometry is a test where they essentially measure the pressure in the rectum and what's going on with the sphincters. So they can tell anorectal manometry and defecography are two tests that give us really detailed information about what's going on with that process of elimination. Okay, you drink 8-ounce glasses of water daily. That's pretty good, about 64 ounces. Walk 2 miles daily, nothing helps. Psyllium worked a little, stopped, Miralax some, then stopped. Now you're taking 2.5 teaspoons magnesium citrate calm in small amount of juice daily, helps some, but nothing normal. Each morning upon rising, 2 glasses water, 2 cups strong tea. Go 3 times an AM after water and tea, but takes forever and stool never normal. Now vacillates between constipation and diarrhea. Desperate, help. How much fiber daily? Okay, so I want you to make sure in your diet you are getting 35 grams of fiber a day. And here's the thing, Lynn, I don't want any of that fiber coming from packaged food. So I don't want you getting any credit for the bread or the pasta, etc. I want you to try 35 grams of fiber a day from fruits and vegetables and beans, legumes, okay? And I want you to bump the water up from 64 ounces to 80 ounces. I want you to try a little acacia fiber in the morning. Start with 1 teaspoon in the morning, work your way up to 3 teaspoons. And I want you to try 2 oxypowder capsules at night. And again, I am not giving you medical advice. Okay, just educationally, hypothetically, if you were a patient who came to me and we're doing this, these are the things I would tell you. Bump your water to 80 ounces, 35 grams of fiber from fruits, vegetables, nuts, seeds, beans, nothing packaged. So even if you're eating sweet potato chips from a bag and it says 8 grams of fiber, I don't want you to count it. But if you are baking a sweet potato and eating it, you get to count it. Okay, so we're not counting the processed grams of fiber. Going to add acacia, ACACIA, acacia fiber in the morning. Start with a teaspoon in the morning, work your way up to 3 teaspoons, and oxy powder magnesium, 2 capsules at night. And let's see how that goes. Report back. All right. SITS marker test, all good. Lean to constipation, but very healthy diet and hydration. 50 years old. For years, do not pass gas. Only happens during bowel movement. Even then can be difficult, which is gas and bowel movement. That's kind of fair passing gas, if not on toilet. Also do have a voluptuous colon. Very interesting. You know, passing gas is kind of like the difference between breathing and yawning, right? So we are breathing all the time and I'm not thinking about breathing. It's, you know, that automatic sort of involuntary thing. But then when I yawn, that's making me yawn. Or taking a deep breath, like a sigh. So when I take a sigh, it is a very sort of intentional, I'm going to take a deep breath in, I'm going to breathe it out. So that's different from just my regular breathing that's happening without me being really aware of it or thinking about it. So there's passive diffusion of gas that's happening from the rectum in all of us, and somewhere between 0.5 liter and 1 liter a day. And then there is flatus or a fart. There's like a more, you know, voluntary or sometimes involuntary expulsion of the gas. So you may not be passing gas in that sort of voluntary controlled way, but there is likely that passive diffusion that's still happening. But you know what that tells me, Carrie, is that you may be a little bit blocked down there with stool. And you mentioned, you know, lean to constipation. And so I wonder, And plus with a voluptuous colon, I wonder when you go, if you are maybe having incomplete emptying. The technical term for that is tenesmus. And I'll tell you, it's the new type of constipation, kind of like the new type of insomnia. Isn't that people can't fall asleep? They fall asleep, they're tired, but they wake up and they can't get back to sleep. So that is a kind of insomnia that most people suffer from. Fall asleep fine, but then wake up for some reason to pee, hot, just wake up. And then the mind, is just going. Our computer, we can't shut it down, right? And so same thing, most people who see me for constipation are not coming in saying, I only have a bowel movement every 4 days. They're talking about small, stuttering, pellet-like bowel movements, incomplete emptying. And usually that is an issue of the bulk. So again, for you, I think trying a little acacia or maybe acacia psyllium mix is a good idea to see, because maybe what's happening is that you have a stool down there in the bottom that's kind of blocking more of the gas expulsion. All right. Thank you so much for sharing that. And yeah, somebody's commenting COVID time was cruel with an IBD flare. There's a product, Travel John. Thank you for this. That is excellent for travel and emergency and comes in sizes, fits in your glove compartment. Travel John. Okay, I'm writing that down. I'm going to check that out. Thank you so much. I always say everything useful I know, I learn from patients. So I'm learning stuff from you guys. Thank you. Travel John. Okay, we'll have to check that out. A stool-powered car may motivate myself and my patients to increase dietary fiber intake. Yeah, can you imagine, Jennifer? So you just have to eat more fiber, and that's making your fuel to power your car. I love it, right? It's very green. Yeah, slippery colitis. Again, Harini, not one that's been well studied. The supplement that's been the most well studied for colitis is turmeric, curcumin. And that has been shown in some studies to be almost equivalent to 5-ASAs, to 5-aminosalicylic acids like azole, et cetera. So whether you're using some fresh turmeric root or using some curcumin in your cooking, that has been clinically, scientifically shown to be very helpful for colitis. Okay, does a furanol work with urge incontinence where there's a sudden explosive emptying of the bladder, or is the device overwhelmed by the volume? No, it is a big device. Like, I don't think you can overwhelm this device, but urge incontinence is a real thing. And, for those of you who, like me, are on the other side of 50, it tends to be a bigger problem in the second half of life where, it's like, as you see the toilet, literally, the gates start to open more for urination than for stool. But yes, that female urinal will work. I mean, there were a lot of different ones I got, and some were little and dainty. I got like the good, industrial looking one. So it's like a urinal, like you would see that they give, men in the hospital with a handle, but it's got this funnel thing. Okay. And Lynn says, never had diverticulosis as far as I know, not sure what it is. Okay, Lynn, so go and look at the report, and then let me tell you which office hours it is. So I have it on my calendar. It's next week. So join us, Lynn, and remember, these are taped, but join us live if you can next week, because when I describe diverticulosis, I have a funny feeling that I'm going to be describing what you're experiencing. Okay, so tune in next week. Okay, do mesalamine enemas reverse the lead behavior or colon with sigmoiditis? Yes, Harini, topical therapy for colitis like a mesalamine enema, which is again a 5-ASA, can heal that inflammation and improve that fibrosis. So it's a good question. How does diverticulitis affect bowels if you are constipated? Okay, so remember, diverticulitis means inflammation of the diverticular orifices. The general condition is diverticulosis, meaning you have these potholes in the colon. And diverticulitis means they're inflamed. So I think maybe you're asking, Lynn, how does diverticulosis, the presence of the condition, affect bowels if you're constipated? That's all I'm going to be talking about next week, how the potholes fill up with stool and, what that means in the rectum, and the stool is in the sigmoid instead of the rectum. So I don't want to, spoiler alert for next week, but that's what I'm talking about. Okay. And Carrie says, yes, definitely incomplete. if I have a sec, is breakfast important? Adding all that fiber to space it out. I do not empty fully, always feel it and take listen suppositories because can't stop feeling. Okay, Lynn, you and I have a date next week, but for now, whether you have it at breakfast or lunch, dealer's choice, but having fiber early in the day is important. Why? Because of that circadian rhythm I talked about, because your bowels really slow way, way down. The whole peristaltic movements, digestion slows way down once the sun starts to set. And so that means if you're, having your psyllium husk at 10 o'clock at night, it's just sitting in your stomach. It's not making it down to the colon. So the fiber in the morning is very important. You always want to do a fiber supplement, high fiber meals as early in the day as you can. All right. Acacia powder you can get online. I like Heather's Tummy Tamers as a brand, but anything that says pure acacia fiber. Disposable urinal bags from Amazon. Thank you for sharing. Oh, yes. I'm so sorry about that. Using that term stuttering. Yes. What I mean is basically bowel movements, like you have a bowel movement and then another one and then another one. So thank you for pointing that out. And I apologize. Besides oat, which seem to bloat a lot, no celiac, what else is good for bulking stool? All right. That's such a good question, Carrie. So from a food point of view, there's tons of things. And, we think of our root vegetables, like sweet potato is great. When we think of grains, brown rice and quinoa are fantastic. You said oats are a little bit of a problem. All those fibrous vegetables like asparagus, broccoli, celery. And when you eat things like asparagus and broccoli, try and eat as much of the stem as possible because that's where most of the fiber is, right? When you think about like a lettuce, greens are great, but lettuce is not really a high fiber food, has other phytochemicals in it that are good for us, but it doesn't, or cucumber, that's mostly water, right? So you want to think about the dense fibrous vegetables. So that would be cruciferous vegetables like broccoli and cabbage and kale, cauliflower. There'd be things like celery. And again, asparagus, where you're eating as much of the stems as possible. So all of those things are good. And then one of the best foods for bulking the stool are legumes or beans. So that could be black beans, it could be chickpeas, it could be lentils. And again, I told you one of my favorite like stool bulking meals are lentils, and I cook them with a lot of onion and garlic for added fiber. I put a lot of curry in there. Sometimes I use a little coconut milk. They're very flavorful. Brown rice and sauteed spinach. And that for me really gets things going. So don't forget about the beans. And yes, the beans can be gas producing. If you want to get less gas from them, make sure you're not using canned beans, soak them overnight, or cook them with a sea vegetable like kombu. Helps to cut down on the gas. Okay. Somebody mentioned that they've used Heather's Tummy Tamers before. Yeah, you're right, Lynn. Gastroenterologists just scope a lot. They do. They do. And, colonoscopy and endoscopy is important, right? Colon cancer screening, removing polyps, all of that. But there's a lot more to what's going on in our digestive systems than just that. And that's why I enjoy providing this. Okay. Do animal products slow the system? Yes, they do. Because animal products have a higher fat content. They're harder to digest. It's a slower process. And they have zero fiber, right? So that's what, meat, chicken, fish, all of these things have in common. They have zero fiber. And fiber is really the key to gut motility. So it doesn't mean you can't eat any animal products, but you want to be mindful about that balance and make sure you're getting lots of fiber in. Okay, Carolyn is sharing her Go Anywhere toilet kit, basically a large bag with absorbent material, folds flat and small, but can wrap bag around you and squat, can set on the ground or buy a frame used for camping or backpacking when not allowed to leave any fecal trace. I love it. I love it. Yeah, so, somebody's asking about lectins and lectins, it's almost like a religion. Like, do you believe lectins are bad or not? I don't believe lectins are harmful, but I will tell you, everybody has their own personal body chemistry and has to figure out, what works for them and what doesn't. So yes, a lot of the foods I recommend to my patients are high lectin foods. And, I'm never just, when I'm in a therapeutic relationship with somebody, meaning that I am their gastroenterologist, I'm not just saying, eat this, don't eat that. I'm asking them to try things and notice what happens and report back to me. And it is very much a dialogue, right? And a progression. So that's really not possible to communicate that in a one-time thing where it's a one-sided conversation I'm having here with you, and it's not in a therapeutic setting. So again, I would advise you to experiment, play around, take notes, see what works for you. And if lectins don't work for you, so be it. But that's not a general advice that I can give people is avoid lectins. The way I can tell you, avoid soda. I can tell you for sure, avoid soda. There's nothing good in soda. Nothing good will come of soda. I can tell you with 100% certainty, there's certain bad foods. They're mostly not even foods. They're sort of conglomerations of chemicals like soda that are bad for you. But when it comes to foods that are more natural foods, everybody, again, some people react to things differently based on what they tolerate. And, everybody has to go on that journey and figure out what works and what doesn't. Okay. Will I be holding a drug-free IBD class in June? We're going to be doing drug-free IBD in July. People wanted to know, they're like, well, if it's virtual this time, why is there a waiting list? And that's because we beta tested the course a couple of times, and we're doing some fine tuning in order to have the experience that feels like it's live. There's a lot of work that has to be done. We've collated all the FAQs and all the video segments, and basically we're making it better than ever without a live component, and that's taking a little bit of time. So we're looking for around a July 4th launch, and we'll send stuff out. And I have to tell you, drug-free IBD, and I think you know this, it doesn't mean like drugs are bad, and it's specific drugs, right? We're really concerned about drugs that suppress or modify the immune system. So that would be drugs like biologics, steroids, and drugs like methotrexate and 6-mercaptopurine and so on. Because while those drugs can work fabulously for autoimmune diseases, they do have the downside, which is that they suppress the immune system or modify it in some way that makes you at greater risk for infection and for cancer. And it's not a great time to be at higher risk for infection or cancer for that matter. It's never a good time for that. And so, what I've spent really the last couple of decades in my practice doing is helping patients with Crohn's and ulcerative colitis in particular, some other autoimmune diseases, figure out if they are candidates to avoid those drugs, taper them off, get off them completely, and how to do that. And so what we're trying to do with the course is give people that very specific advice. And I will say in what I consider a responsible, medically responsible way, which is, check with your gastroenterologist, make sure you're a good candidate, let them know you're doing this. Here are some signs to watch out for to suggest that things are not working, or here are some situations where you might not be a good candidate for this, right? So it's not a matter of these drugs are bad and food alone is, ideal and good. But what I found in my 30 years of being a doctor is that many people can actually get off these drugs completely or decrease the dosage when they do some other things that involve changing the diet, probiotics, some supplementation, et cetera. So thank you for asking about that. And thank you, Andrew. That's so sweet. So I think that is all oh gosh, I forgot all these other questions here that I didn't get to in the Q&A because I was on the chat. Increased risk of having infection in your rectum if the stool is held for too long. Increased risk of hemorrhoids, fissures, diverticulosis, but not infection. And, one of the theories about colon cancer is that it is correlated with constipation, because remember that these are toxins that are meant to be eliminated. And if they're sitting and exposed to the mucosa, the lining of your colon, for longer than they normally should, there are a lot of theories about what that can do and, whether that is a risk factor for colon cancer. And in some studies, long-term constipation is a risk factor along with other things. Okay. A session on the role of hormones, such as estrogen on the GI tract and bowel movements. That's such a good idea, Jill. I will add that to the list maybe for July, because I'm making up the list for July office hours. So let me make a note of that. July office hours. I still like to write things down with a pen on paper. So I'm going to take your suggestion, role of hormones, but you got to promise to come, Jill, okay? And bring some friends, okay? I'll do it because you asked, but bring some friends. Role of hormones on GI tract. So I think I would focus on estrogen and progesterone. That is such a good idea. Thank you. You guys are awesome. Speaking of gas, so people who sometimes could perhaps benefit from fiber but have a problem with gas, any thoughts on ways to regulate, reduce gas and gas pain without cutting out fiber? Yes, absolutely. So I'm a big fan of Beano because remember, a lot of this fiber has a poorly absorbed carbohydrate in it called raffinose. And Beano has an enzyme, alpha-1 galactosidase, that can break down that raffinose. So doing a little Beano can be a great help. And some of the other things I talked about, like soaking the beans and stuff overnight, can be helpful too, and the kombu, etc. But try a little Beano. Will oatmeal also help someone with IBS-D, not just UC? Yes, and remember, IBS, IBD, two completely separate things. So ulcerative colitis is a type of inflammatory bowel disease, chronic autoimmune condition. You have ulcerative colitis, you have Crohn's disease. IBS, irritable bowel syndrome, is a functional bowel disorder with diarrhea or constipation, completely distinct from UC as a form of IBD. But to answer your question, yes, oatmeal in people who are having diarrhea, whether it is from colitis or IBS-D, as you point out, and thank you for that, can, in many people, help to sop up those multiple bowel movements and provide one more solid bowel movement. So definitely something worth trying. And I think with that, we are past time. So I'm going to have to say goodbye, but always so great being with you guys. And please join me for diverticulosis. If you know somebody, even if they haven't been diagnosed, but they're having those incomplete bowel movements, tenesmus, are going, and they're going again, and they're going again, and they're going again, particularly if they're over 40 or 50, there's a high likelihood. Okay, everyone. Thanks so much. Bye-bye.